So before I start, does anyone know what this is? Anyone? No one? All right. So I'm going to start. We're going to go back a couple of hundred years, all right? And so this is the original stethoscope. Now, you might be asking, why am I talking about a stethoscope? We'll get there. This was an innovation. So a couple of hundred years ago, physicians started auscultating the lungs, which was an innovation. And that's hard for us to think about because now it's, the stethoscope is the universal symbol of medicine. And we think that it's been there for forever, but it has not. And so this man, Laennec, in France, starts auscultating with some of his colleagues, but the story goes that he's embarrassed. He doesn't want to put his ear on the bare chest of young women, and so he gets an idea from children that they were playing this game, listening to a stick, that if he rolls a tube of paper up and then later a wooden tube, that he can actually hear inside the chest, and then he can put a little bit of distance between him and the patient. So this is an innovation. Very quickly, physicians developed the stethoscope. You can see in 1860, it looks about the same as it does today. Now, why am I talking about that? Because what has happened in those 200 years? A lot of things, but diagnostic imaging, right? And so diagnostic imaging has been around for about 130 years now. And so we all who practice clinical medicine realize that there's a diagnostic gap. And what do I mean by that? There's a gap between what the traditional physical examination can tell us at the bedside, with a stethoscope, for example, and what computed tomography, MRI, ultrasound can provide for us. There's a huge gap. And so things have developed since its original innovation because we continue to innovate in medicine. We're innovators. The problem, though, is that we're teaching this skill that was a huge innovation, but now it seems like it's difficult. It might take a lot of time, minutes, days, to find an answer with a stethoscope, when all of the residents that I know talk about the easy path or the easy button or the truth scan, as they call the computed tomography or CT scans. It's like walking through the park, and you might get to the same destination. You might find the right answer both ways, but one way looks like it's climbing a rock face and it's super difficult. And then the other one is sometimes a click of a button and it's the easy answer. And so this diagnostic gap exists. It's real. And when you're there with the patient in real time, you think about, how do I get there? How do I get the answer? And one of the things that can bridge that gap is ultrasound. And so I'm not talking about ultrasound, this big, huge machine that's being wheeled around. We're talking about a variety of ultrasound modalities, and it has the potential to be a true stethoscope. Why do I say that? Well, many of you speak Greek. I don't, so I'm going to not try to pronounce the Greek, but the word stethoscope comes from looking inside the chest. And so a stethoscope is not a true stethoscope in the sense of it, because it should be probably like, a stetophone. But really, ultrasound has the opportunity to be a true stethoscope. It bridges that diagnostic gap. What it does is it brings modern medical diagnostic imaging to the bedside, and in real time you can get information to help guide decision making with your patients. And just to kind of build off of what Robert was talking about, this can be taken anywhere. And so, yes, this is a picture of me. I look a little bit different a few years earlier. But I'm in Nicaragua at a rural clinic in the middle of the jungle. I have an ultrasound device there. And then this other picture is my friend. Sorry, I'm standing in front of the slides here. This is the picture of my friend and me. And what are we doing? We're ultrasounding each other to see if we have altitude-induced pulmonary edema, which thankfully we did not at that time, at 10,000 feet, maybe if we'd gone higher. Where is ultrasound heading? We talked about it being in the space station. We talked about it being, taking it to Antarctica. But there also is a huge role for telementoring. And so I had a meeting last week with a group of physicians in Tanzania at a hospital in Mbeya, and they had their images, and they were showing them in real time, and I was giving them pointers on how they can obtain a better image. And so it's a really interesting thing. There's all these projects where people are having midwives in Uganda, for example, getting images of high-risk pregnancies. They're taking these images, and through Wi-Fi links, they're sending them to radiologists and to other people who are helping to help these patients out without actually having to fly to these areas. Ultrasound is also getting smarter. And so what do I mean by that? Machine learning and artificial intelligence are taking off, and these machines are now acquiring the images themselves. So I mean, of course, you still have to put the probe on the chest or on the abdomen, but the machine is helping you out. It's like if you've driven a car with the steering wheel that helps guide you, it's guiding you get that image, and then it's telling you its interpretation. And so if anyone's looked at an electrocardiogram where it gives a preliminary report at the top, this is like that. So it's guiding you. The barrier to entry is decreasing, and it's getting easier and easier to obtain clinical information at the bedside to bridge this diagnostic gap. And so point-of-care ultrasound is just simply ultrasound performed at the bedside or at the point of care in real time by the healthcare provider to help guide decision-making in real time. And so it can be used intermittently throughout the patient encounter. And so you take a good history, you do physical examination, then you use ultrasound to help augment that physical examination in a diagnostic way. You can then use it to potentially guide a procedure, therapeutic or diagnostic procedure, so guiding a needle, for example. And then the other thing that's really fascinating that's developing is it can help monitor patients. And so it can predict which patient with heart failure is going to be admitted to the hospital soon. You can see pulmonary edema developing. You can prognosticate. You can determine which patient has a worse prognosis with heart failure, for example. You can follow patients serially who have clots to see whether there's resolution. You can follow pneumonias up. You can look at patients with pulmonary fibrosis or inflammatory lung diseases and then track progression over time. And so there's a whole lot of different and interesting things coming out with point-of-care ultrasound. And so it doesn't just encompass one scan or anything like that. There's a lot of different uses. And there's a spectrum of use. And so some people say this is just an extension of the physical examination. So you go and you look at the patient, you feel, you touch, you listen, and then you insonate or use ultrasound. And that's integrated into a physical examination. But that goes all the way up to doing comprehensive or consultative ultrasounds. And so we're talking with one of your faculty members, we were talking about gastrointestinal ultrasound. If you're using that to monitor someone with inflammatory bowel disease, that's a little bit different than an extension of the physical examination. That's a little more of a comprehensive exam. But there's a spectrum of use of ultrasound at the clinical point of encounter. Ultrasound is now standard of care for many procedures that are performed. And so it's the standard of care for central line insertion or central vascular cannulation. Arthrocentesis, there were several studies that showed that improves that. A standard of care for paracentesis, or taking free intraperitoneal fluid out of the abdomen. Taking free fluid out of the thorax, so with the thoracentesis. And so it doesn't just help you see better. There are many studies for these procedures showing that it can reduce complications, reduce the number of sticks, improve success, and even potentially reduce infection rates. And so moving beyond that, though, what am I talking about with the physical exam? And so we've always touched patients. We've always put our ears or stethoscopes to the patients to listen. We've always tried to probe every orifice and look deeper if we could. So why not look a little bit further? And this is a really cheesy movie from Laennec inventing the stethoscope, but I'm very confident that if he were here today, he wouldn't be using a stethoscope that much. He would be using an ultrasound. Why? Because this man was an innovator. He was working with innovators, and this is an innovation that bridges that diagnostic gap. And so it's a new specialized tool. And so we already use sound when we listen with the stethoscope. This is just allowing us to look a little bit deeper, confirming what we feel, and it becomes part of the patient-physician interaction. And so as a hospitalist, as an internal medicine physician, I'm walking into the room, I'm taking a history, and what am I doing? One of the first things is I'm taking my handheld ultrasound device out of my pocket. I also have a whole another pocket full of little gel packets. And as I'm telling the patient, I'm saying, hey, listen, I'm going to take a look at you with ultrasound. And I'm booting the machine up. I'm talking to them. I'm getting a good history. I'm looking at them. I'm doing a limited physical examination. And then I'm taking that ultrasound probe and I'm putting it on their chest. I'm listening to them, and then I'm looking. And then I'm looking at the lungs. I'm looking at the heart. I'm looking at the abdomen. And it becomes part of that patient-physician encounter. And is there value? And so there are many studies showing that when you use ultrasound, you arrive at a diagnosis faster, and often it's more accurate than a physical examination. It generally improves safety and the accuracy of procedures. It may reduce length of stay in emergency departments and hospitals. It can predict admission or readmission to the hospital. And it generally increases patient satisfaction. If you take that ultrasound and you turn it around or turn the screen to the patient, especially if it's on your smartphone, you say, these are the images of your heart. This is why you need to be taking your blood pressure medicine. This is why you need to be taking your heart failure medicine. This is your heart. You know, what we're trying to do is to help you out. And it really increases patient satisfaction. And then it may reduce costs. And of course, I'm not exactly sure about the healthcare system here, but in the United States, at least, and in other parts of Europe, there's been suggestion it may reduce cost. Here's the same video. I didn't know we were going to put the same video in our talk. But you know, you can imagine that if you're listening and you close your eyes, it can be very difficult, particularly as a student or resident learner, until you've gotten many hundreds of hours of listening to patients to interpret where is the murmur. When is S1, S2? I remember learning this. You put the ultrasound on, and then you turn that Doppler on, and then you can see the regurgitant flow. And so you see blue away, red towards, or BART, and if you see here, there's regurgitant flow going across this valve right here, and you can see the aortic valve here. Not only is there turbulent flow, but there's regurgitant flow as well. And this patient had quite a sick heart. And the cardiologists are taking note of this. And so this is a 2018 article from a cardiologist saying, perhaps it's time to add a fifth pillar to the physical examination. So inspection, palpation, percussion, auscultation, and insonation. And ultrasound is dynamic and repeatable. And so you can follow patients over time. You can monitor the response to your interventions. And so if someone has shock, you can then give them a fluid bolus, and you can monitor the venous response. You can see how the vein is expanding or collapsing in response to that intervention. You can look at the left ventricle. You can see whether you've given too much fluids, for example, if the patient starts developing cardiogenic pulmonary edema or fluid in the lungs. And then again, you can ensure resolution if the patient is about to be discharged, and it can make me think about cautioning them. And then there's even some interest in some studies of sending patients handheld probes to monitor their own hearts and lungs in the outpatient setting. And so just to put it out there for anyone who gets super interested in this, that's also a next wave of this, is to have self-monitoring patient assessments at home. Perhaps there'll be sensors with this as well. Moving beyond the traditional physical examination, though, there are just some things that you can get with ultrasound that are unknowable by the traditional physical examination. And for example, there's no physical exam maneuver that can estimate left ventricular function. And so we can now diagnose a lot of conditions at the bedside that historically we just could not do. And so for example, if you have a woman in her 40s who's complaining of right upper quadrant abdominal pain, and then maybe she has some postprandial pain, you can then look and you can think about finding a gallstone, for example, and see this is a hyperechoic or bright white stone inside of a fluid-filled gallbladder. It's casting a shadow behind it. It's very characteristic of a gallstone. You have a woman who's a smoker whose legs are always a little bit swollen. And she comes in and she says, my right leg is a little bit more swollen today, and perhaps it's a little bit more red. And for anyone who does practice medicine, this is always on a Friday afternoon. And if you put the probe on her leg and then you look and you see that this vein that should be black here, the common femoral that's splitting into the superficial and deep femoral vein, it's not compressing. And so if you look, there's actually some bright white material in there, and this is a clot. And so if you rule this in, you might be able to immediately change the entire course of this patient's workup. That you might avoid a hospitalization, for example, and be able to have her take an anticoagulant and then come back in a week. This is a patient who comes in with pleuritic chest pain. And so I don't know how many of you in your clinical years, but this is a really tough one, because one of the first things you start thinking about if someone's coming to the emergency encounter is a pulmonary embolism, which is a clot into the pulmonary artery. And so that can be a life-threatening diagnosis. But if you take the ultrasound probe and you actually have the patient put the probe onto the spot that hurts the worst, what you can do is you can actually sometimes find other things that are not a lung clot. And for example, if you look here, this is a rib, and there's discontinuity here. And this is actually a rib fracture. You can see a small periosteal hematoma there. And this is a patient with a rib fracture. And sometimes older adults remember falling, sometimes they don't. But this is one of those things where I've even found this in patients that have had a full workup. They've had chest x-rays, they've had rib series x-rays, they even had a CT scan looking for pulmonary embolism, and they're still saying, doctor, I still hurt, why do I hurt? And you put the probe on, you find this is a huge catch here. This is a woman who came, and these are all, by the way, real cases. These are all my real patients. And so in this case, you have a woman who's coming in with chest pain and fever, and that can be a real tough one. And during the COVID-19 crisis, there's actually a fair number of people, and you're trying to sort out, is it from the cough itself? Had they developed a pneumonia on top of the cough? Have they developed a blood clot in the lungs? And so, common things here. And so in this patient, a middle-aged woman, she's coming in, and what we're looking for here is there's black fluid around the heart. And if you look, this is pericardial effusion. And the heart itself, the pericardium, for anyone who's looked at these images before, it looks a little shaggy here, and this is an inflammatory pericardial effusion. She has pericarditis. And so this is a really interesting find here, and it changed her workup as well. I put this up here. If you look, this is another heart. So you have left ventricle, the right ventricle here, right atrium, left atrium. This is the inferior vena cava, or the main vein draining into the right atrium. And if you look, there's fluid around the heart. And this patient actually was diagnosed with sepsis, or a severe inflammatory response to infection. Their blood pressure was really low, and they were on medications to raise their blood pressure, vasopressors. And this patient had been on escalating number of vasopressors. They kept adding medication to raise the blood pressure, and were treating with antibiotics. They're thinking that this was sepsis and septic shock. And they were not realizing why the patient was declining so quickly. And a pulmonologist and I clipped these images, and we found that actually the patient had pericardial tamponade, or the fluid around the heart was causing the patient to be in shock. This patient had the fluid drained off and immediately started improving, and we drastically changed that. And so I put that up there as this was a missed pericardial tamponade. And it seems like this could be uncommon, but the fact is you don't get an echocardiogram on every single patient who comes in the hospital, or this patient may have declined so quickly you might not have been able to order one. And so if you're able to do this yourself at the bedside, this is something that immediately changes the trajectory for this patient. And I really think with these machines and this teaching and technology expanding, this should really be a never event. We should never really miss this in a patient with shock anymore. This would be like missing an ectopic pregnancy when you have an ultrasound sitting right there and you're trained in how to use it as an obstetrician. So this is a really interesting case here. This is a man in his mid-20s. He's an intravenous drug user. He's been having some fevers and night sweats. He came into an urgent care clinic, and if you look, he has some swelling right here. And if you look right there, they actually tried to just put a needle in this to drain it off because they said that he had a chest abscess. And so this patient comes to the emergency department, and he had a very abnormal chest x-ray. So I went to the bedside, and this is what I saw. And so this is a handheld ultrasound unit. This is a little older one, so the images are a little fuzzy. But if you look, here's a rib. Here's an intercostal muscle. Here's another rib. There's an intercostal muscle. This is his skin up here. He's got fluid below the ribs, so he has a pleural effusion or fluid there. But if you look, there's actually all of this stuff swirling and communicating with this abscess. And so what's happened is this man has developed an empyema, so a bacterial infection of the pleural space, and it actually ate through his intercostal muscles and was about to pop out of his chest. And so this is what's called an empyema necessitans, or necessitatis. You can see both names. You really don't see it anymore. This is almost something that we saw in the pre-antibiotic era, and I use the we collectively because I was not practicing then. But if you read the literature, there are very few cases of this reported, and this man, because he was using drugs, he was just sitting up and ignoring all of his symptoms. But he really didn't look that toxic. This is really just fascinating here that this chest abscess, you put the ultrasound probe on, and of course immediately got a CT scan. We had a cardiothoracic surgeon come in, and eventually he actually had to have a pleurectomy where they took the entire pleura out just because it was so infected, and he actually had a good outcome. And then this is his image at the lung base. And so what we're looking at here is his liver, and we're just seeing this massive amount of fluid here, and this is just all pus sitting in that chest cavity that was drained out. And this is actually the video. They're inserting a chest tube, and you can see that this was definitely communicating with that empyema because this is his chest wall rising and falling with respirations as they're draining all of that infection out of his chest. And I had to take the sound out of it because there were quite a few off-color comments about how this looked here by the pulmonary physicians doing this. But we presented this one at a national chest conference. This is a 56-year-old guy. He came in. He had a diabetic foot ulceration on the plantar surface of his foot. Sometimes these need antibiotics. Sometimes they need debridement. Sometimes it can change a lot. His leg was a little swollen. It looked like he had cellulitis or inflammation of the soft tissue as well. And I was telling the residents that for every patient with cellulitis, you might miss an abscess. And so it's really important to make sure that you perform an ultrasound of patients' legs, particularly if they're quite swollen, because you might miss something that's surgically correctable, so a drainage procedure as opposed to antibiotics. And I found something very curious. And so a tissue-air interface on ultrasound is bright white. And what we're seeing here is skin, soft tissue. This is bone down here. But we're seeing this bright white stuff right there that doesn't correlate to any bone that's just isolated. And that's not a foreign body. This is actually air in a fascial plane. And this man was developing a necrotizing soft tissue infection. And I've diagnosed necrotizing soft tissue infections several times, and I've had to call surgeons up about this because they're not always clinically apparent at first. I had a man who developed a sternocleidomastoid necrotizing infection, and I basically had to bring the ear, nose, and throat doctor to the bedside to show him the swirling and the air within that muscle. But point is, not everyone has received the same training in this. And then, if you get this training and you're starting on this path, you're going to be able to catch all sorts of really fascinating things. Unfortunately, this guy declined amputation. In the interest of time, I'm not going to get into the psychiatric evaluation, but when he finally did have to get his leg amputated, it was a pretty high amputation, but he developed myositis, or actually pus inside the muscle. And this is all air inside of this man's muscle belly here, so it's just an interesting image. So it's not just quick looks, though, too. You can do a comprehensive ultrasound exam. And I put this up here to just show you a little bit about what I'm doing almost on a daily basis. And if for any of you who've done clinical rotations, I'm not sure if people are quite as large as they are in the United States, but this guy comes into my hospital basically every day, and he always has a cough because he's a smoker, and he's always got a little bit of swelling in his legs. And it's really tough to tell, does this patient have extra fluid that I need to take off of him to help him feel better? Does he have fluid in his lungs? If you put a stethoscope on this guy, it's going to sound like nothing, because you can't really hear through that chest wall there. And I'm not judging this man. I'm just saying it's a very difficult physical examination. Looking at this man's neck veins, anyone's learned the cardiovascular physical exam, it's basically impossible. He's got this huge beard. Point is, we don't really know. So I developed an exam that I call the iceberg exam, or the internist congestion exam. And patients always come to us at hospital admission, but congestion and congestive heart failure, fluid that backs up from the heart, begins way below the surface, and that iceberg is lurking deep down there. And the first things you might see are things like left atrial dilation, inferior vena cava dilation, hepatic vein enlargement or venous reversal. And then really only when you come above the surface do you start seeing patients that have edema in the lungs, fluid outside the lungs, free fluid in the abdomen. But with ultrasound, you can look for each of these things and put them all together. And so you can look at the top of the lungs or the tip of the iceberg to look for pulmonary edema. You can look at the right upper quadrant and the left upper quadrant for free fluid. And so we're seeing free fluid both in the abdomen around the liver here, as well as above the diaphragm in the thorax. And right here what we're seeing is loss of lung aeration. You get these characteristic vertical artifacts that appear and disappear in real time with pulmonary edema. You can look at the vein, and this is the inferior vena cava, again, draining into the right heart. This is the hepatic vein, and it looks very, very dilated. It's just a pure pattern recognition thing. And then you might look at this heart, and you can see that this chamber, the right ventricle, the aortic outflow tract, are about the same, but this left atrium here is huge, is much bigger. And these are the sorts of things that you can begin learning in medical school, the things we start teaching our medical students. And you can put all of this together, and this is very consistent with acute decompensated congestive heart failure, because he has signs of both circulatory and tissue congestion. And then if you're thinking about looking at the neck veins, you can even look at the height of the neck vein and use it to approximate the height of the venous column, looking for right atrial pressure. But point is, you can do all of these different exams. If you haven't learned this, is okay, but point is, this is what I'm doing. I'm doing all of these things for my heart failure patients most days, putting it all together. And I put this up here because this might seem daunting to get there. But what are these images? These are literally the first images I pulled off of what the medical students submitted last week. So these are not images that someone got a year or two ago that I put up here. And I didn't label these. This is a third-year medical student that I taught how to do ultrasound last month. You know, they've been building on it. But the point is, this is something to think about and reach for. These are not images I collected myself. These are images that collected by a third-year medical student who labeled them himself. And he got the descending aorta a little bit wrong. I gave him feedback on that. It's actually right here. But he labeled the right ventricle, the aortic outflow tract, left atrium, and left ventricle all correctly. He identified that this is a lung, and you can see that lung kind of flapping in there. We call it a jellyfish sign when the lung flaps in free fluid. This is the liver, the diaphragm, and he said this is abnormal, pleural fluid, correct. He then put Doppler on. He took a little step further, and if you look, it's blue and red in this hepatic vein, and that's reversal of venous flow, and that's because the pressure in the heart with contraction is actually backing up with each contraction of the heart. And you can see reversal of flow consistent with really severe tricuspid regurgitation. But he identified that and sent these images, and needless to say, he got an A. But these are images collected 2 weeks ago. So putting it all together, ultrasound complements you being a physician or veterinarian, I forgot there were veterinarians here, and I'll say one last thing at the end about veterinarians, which is very positive, is that you with the patient, it complements a good history and physical examination. This is not replacing looking and talking to people. You still have to look at them, talk to them, or communicate with them, and it confirms the suspicions you may already have, and you're answering quick yes or no questions, but you might put it all together as part of a comprehensive exam. But its success as a tool really depends on you as a clinician. And this is my favorite quote about ultrasound, that a fool with a stethoscope will still be a fool with an ultrasound. And what does that mean? This is a tool, and we need to know how to use it correctly, and that begins hopefully in medical school, and y'all are already on your way of doing that, which is great. And the last point about veterinarians is they've actually been far ahead of physicians, and it's still in internal medicine. The internal medicine textbook of reference is called Harrison's, and even in 2010, Harrison said that the lungs cannot be imaged with ultrasound. That was still in 2010. The veterinarians started imaging horses' lungs back in the 1980s. So they did that, and then the French physicians, pulmonologists, discovered it by reading veterinary literature, actually, and started doing lung ultrasound in the 90s, about 10 or 15 years. But you can imagine how difficult it is to get a horse into a chest x-ray, right? Versus you take an ultrasound and then do that. But point is, the veterinarians are actually pathfinders and trailblazers here. All right, well, thanks.